So yeah, my name is Erin. It's nice to see you all. Thanks for joining us on a Saturday. I'm a 5th year medical student and I'm at the University of Edinburgh. I also intercalated, so that means I took a year out in my 3rd year and I got an additional degree, and that was in development, regeneration and stem cells. So that's about all I have to say about myself, I think. Great, yep, so this is a presentation and it's designed to be really interactive. So I hope that it's interesting for you guys. You can use your mic to answer the questions, but if you're feeling a bit shy, feel free to use the chat, that's also okay. There will be time for questions at the end, but if you have any questions throughout, feel free to just chime in with them as well. My presentation is going to be on the emergency management of an unwell patient. So I hope that this will give you a bit of a taste of the sorts of things that you'd learn at medical school, and we're going to have a bit of a case-based learning thing going on. So we're going to have a patient that we're going to talk about. There we go. So the scenario is you're a junior doctor, so we're skipping forward about 10 years or so, bear with me, and you're in the accident and emergency department and a patient collapses. So what should you do? Does anyone have any ideas?
Call for help.
Very good. That's the one people forget to do, but it's absolutely the first thing you should do. So you call for help, and luckily you're in a hospital, so lots of very useful people will come running towards you. Does anybody have any other suggestions of a management approach?
Check for a pulse.
Check for a
See
pulse.
if they're breathing. Very
good. Yeah, these are really good things. Anything else? Well, I think that's pretty good. So those are really good things to do. And without even knowing it, you have actually said some of the steps of the Abcde approach. So this is a standard approach for assessing and managing a patient in an emergency situation. As you can imagine, sometimes these situations can be quite scary and they can be very stressful. So if you are a doctor and you're on call and it's 3 AM, you're 8 hours into your shift in the middle of the night and your brain is a bit dead and you get called to see someone who's had, say, a heart attack, every single doctor can fall back on this approach, and it's a really, really basic structure that as long as you follow it methodically, you'll know that you're doing the right things for your patient and you can be confident in that. So does anybody know what any of these letters would stand for? Does anybody have any guesses of that?
A is for airway.
Yeah, correct.
B is breathing and C would be compressions.
Very close. So B is breathing and then C is circulation. So compression definitely comes into that. Any guesses at D and E? They're a little bit more tricky. No. So we've got airway, breathing, circulation, disability, and exposure. We'll go through these in a methodical approach. Hopefully we'll be able to get through them all, but we might not in the time that we have. So we'll start with airway. And we're going back to our patient now who's collapsed in A&E. We'll pretend someone's taken them to a bed and they're in a private room and you're ready to treat them. What should you do for airway? Or maybe a better question is, what do you want the airway to be?
Not
You
blocked.
wouldn't want it, sorry.
No, very correct. Yep, so you need an open and a patent airway. So you need an open airway that is going to stay open. And there are some things that you can do to check this, but a really, really, really simple and easy one is the patient talking. If the patient can talk, they've got an open and a patent airway and you don't need to worry about it. If the patient isn't talking, you'll need to do some more tests, and there are things that you can do to manage an airway and keep it open as well. And that includes jaw thrust, chin tilt. So it's a position that you put them into where you tilt their chin back and you thrust their jaw forward, and that opens up the airway. And you can also use these things called adjuncts, which are little plastic tubes that you slip into people's mouths or through their nose, and that will keep their airway open as well. So This patient is talking. She's a bit groggy. She's not really making very much sense, but she is talking. So we're confident that she's got an open airway, and we move on to breathing. Does anybody have any ideas, the sorts of things that you'd want to consider about a patient's breathing?
Good. See if their chest is moving up and down.
Yep, very good. It should be moving up and down. If it isn't, then they're probably not breathing. So other things to consider, you can think about yourself in these scenarios. So if you were feeling unwell, or you were nervous, or you were panicked, things that could change. So your breathing rate, how fast a person is breathing. You don't want them to be breathing too slowly or too quickly. How hard it is for them to breathe. So when you're looking at chest movements, they should be quite subtle. If someone's chest is moving a lot to breathe, that's a sign that it's difficult for them to breathe, and you need to help them with that. But there are also a few numbers that you can get for breathing, and one of them is called pulse oximetry. That's what you use to measure oxygen saturations. So it's basically, it's a fancy little device that uses a laser to figure out how much of your hemoglobin, that's the molecule in your blood that carries oxygen, how much of that is saturated with oxygen. So typically, you'd want someone's oxygen saturations to be about 97 to 100%. That's what you'd expect in a normal person in most cases. But this patient that we have has an oxygen saturation of 91%. So that's lower than you'd want it to be. What should we do?
Call for help.
Call for help. Okay. What do you want the person you've called for help to do?
Try and get the number up.
Okay. And how would we do that?
Use an oxygen mask.
Yeah, exactly. So you administer oxygen. So in hospitals, every bed is connected to an oxygen supply. And there are lots of different ways that you can give oxygen, usually through a mask, different types of mask. It's quite complicated, but you can also use nasal prongs. That's something that you'll probably see in like the TV shows, someone who has like nasal prongs and that's connected to oxygen. So that's what you do. You administer oxygen to this patient and her oxygen saturations go up. So you've done the right thing. Her airway's still open, obviously, because her oxygen levels are going up. And you're going to move on to C. So what should we look at for circulation?
Pulse rate.
Checking the pulse. Yeah, that's a fantastic one to do. Anything else? So another really good one to use, and this is a really simple test that I'm going to get you all to do now as well. So you can look at capillary refill time. So if you stick up your thumb and pinch your thumb for 5 seconds, roughly, and then if you take it away, it blanches white and then it goes back to being a pink colour. And you can do that on a patient, you can do it on yourself, and the time it takes from it to go white to pink should be less than or equal to 2 seconds. Shouldn't be more than 2 seconds. If you're cold, it might be a little bit longer and you're probably fine, so don't worry too much. But in a patient in hospital, that's something you can do. You can look at that and it tells you about their circulation, how well the blood is traveling to their peripherals. And the other thing we can look at is blood pressure. So this patient has a capillary refill time of 3 seconds. That's a bit too long. And her blood pressure is 80/60, which is also quite low. So we want blood pressure to be around about 120/80. Quite a big range. It changes a lot in different people, but we know that her blood pressure is too low. So what do you want to do in this situation? This one's a bit trickier. Okay, so it's maybe not as obvious, this one. What we're going to do is administer fluids. So if she's got poor circulation, you can help that by giving her a larger circulating volume. So if you hang up an IV, which is an intravenous line, it goes directly into a vein, and you can hang up fluids in this circumstance, you just use saline, which is like salt water, not super fancy, but you can stick in 500 mils pretty quickly. Hopefully her blood pressure will go up and you can keep monitoring that and administering more fluid if you need to, keeping an eye on the blood pressure and seeing how that reacts. And at this point, we're feeling pretty happy about her circulation. You've given her fluids, you've given her oxygen, she's got an open airway, and we're going to move on to disability. So, does anybody know what sorts of things you'd want to look at in disability? So this is, yeah, disability and exposure, in my opinion, are the ones that get a little bit less obvious and a little bit further on. So in disability, we're kind of looking at things like level of consciousness. And there's a really, really easy way to do that as well. A quick one is something called Avpu, which is Avpu, and it stands for alert, responsive to voice, responsive to pain, or unresponsive. So if someone's alert, that's quite self-explanatory, I'd hope. If they respond to your voice, then that's sort of the second level, and it means when you talk to them, you get some sort of reaction that they're not alert on their own. Pain is if you do something that should be a little bit painful, they flinch or they respond in any way, or they protest to things that are painful. And then unresponsive is when you get absolutely no response no matter what's going on. And that's sort of like a step. So obviously alert is best and unresponsive is worse. The other thing you should do is check glucose levels. People always forget that, but it's one that's a really easy fix and could be quite a common cause for someone to be very unwell. And then I think we're sort of finishing up, so I'll just go over exposure quite quickly. Exposure is when you simply expose the skin. So you could have done A all the way through to D, and you have a patient who's lying on their back and not moving very much. And until you get to E, if you don't like roll them over and have a look at the behind, then you could have missed, say, like a giant wound on their back or something. So E is really important. It makes sure that you haven't missed anything. This is also the point where you check temperature, which is important. Is usually a sign of infection or inflammation. And you also try to treat the underlying cause at this point. So A to E, the order that we've done, can anybody think why this is a logical order to assess and treat a patient?
Is it like sort of an order of importance?
Yeah, exactly, that's it. So to put it quite bluntly, it's what will kill you first. So if you have a blocked airway, you can't breathe. And that is more important. Well, they kind of go hand in hand, but you need to have an open airway to be able to breathe. And if you're having breathing problems, one of the main purposes of your blood is to circulate oxygen in your body. So your circulation can be working fine, but if you don't have any oxygen to circulate, then you're going to have problems because of that. So it is simply the most urgent thing comes first. And realistically, in this scenario, you guys are in a hospital with loads of nurses and other doctors and other people around you to help. And this isn't something that happens in isolation. You don't do A, B, C, D, E. It's usually happening all at the same time. But if you're ever on your own or there aren't as many people as you want to be, this is the best approach to go for. And whoever's managing the situation is thinking of this approach in their head. The other thing to note is that you should, of course, reassess throughout. So you could do A and someone's alert and they're awake and they're talking and they're fine and you don't need to fix their airway. And then by the time you get to C or D, maybe they're unconscious and the airway isn't as safe anymore and you need to go back to reassess and make sure that that's fixed before you move on. So it's a dynamic process. Some images that illustrate different career options and then including like a group of people that you'll be working with if you decide to become a doctor. And this talk is chatting about a principle that is used in all of these fields. No matter what you decide to go into, there are some things that kind of carry over into all situations. So I hope you all found it helpful. And I think we've got about 5 minutes for questions now. If anybody has any, could be about anything, medical school life, applications, life as a student.
You said that you got a second degree as well when you went to medical school. What's that like?
That's a good question. So this is actually topical because there's been a bit of controversy about this recently. When you graduate, getting jobs after that is based on a point system, and intercalation, having a second degree in any form, gives you an extra couple of points. So it was beneficial, but then people have decided that they're going to get rid of that, and it's causing a bit of controversy. But the point of that is Edinburgh had made it mandatory for everyone to do this. So I think it was something I would have been interested in anyway, but nobody in my year had a choice. Everyone had to do it. And you take a year out. At Edinburgh, you do it in third year. In some of the universities, you do it in fourth year, and you go into a different degree. So I went into fourth year of a biology degree, and I completed fourth year in the same way that everybody else did, who was doing that degree. And then at the end of it, you get the degree. So it's not the exact same one. They get a Bachelor of Science, and I got a Bachelor of Medical Science. So it's slightly different, but pretty much the same thing. And it was really enjoyable. Yeah, I really liked it. I think it's a nice little break from medicine in one way, and it also allows you to develop more scientific skills. So I did a lab project that was based in a wet lab. So I was doing very technical sort of lab work in terms of, you know, pipetting and microscopes and dissections and fancy stuff that I don't really understand that much. But that was really good for me because I got to gain a lot of skills that I never would have done in a medical degree. And there's also a lot of scope as a doctor to do research later in your career. So this kind of gave me a foundation that will be helpful for that as well, in terms of the skills, but also things like reading scientific papers and analysing papers, and like an understanding of biology that's more intricate than you get necessarily in medicine. Any other questions?
Would you say being in like the medical field or like being a medical student makes you more stressful than you would in any other sort of degree or field of work?
That's a good question.
Sorry, Erin, can you stop your share so that obviously?
Oh, absolutely. Sorry. Yeah. Oh, we're all back towards
Yes.
seeing each other now. Yeah, that's a really good question. So I think it's definitely stressful in some ways. And I think once you graduate and you go into a career as a doctor, that can be really stressful, but it's slightly dependent on the career you choose. For example, I'd say some people would consider, say, a career in A&E can be really stressful, whereas there are other specialties that are less stressful. As a student, I think most people are stressed equally. Like, I wouldn't look at other students who go to my university who are doing different degrees and think that they're that much less stressed out than I am when it comes to like exams and deadlines. During day-to-day life, you're fine, but when it comes to deadlines, it does get pretty stressful, for me anyway, but people deal with those things differently. So.
Thank you very much. Are there any other questions for Erin before she disappears?
When you moved to Edinburgh, is there anything that you did that you'd recommend?
For getting into Edinburgh, was that? Yeah, that's a good question. So when I applied for Edinburgh, they did an interview, and they recently introduced an interview process. So the application now is a bit different to when I did it. When I did it, they were very much focused on your personal statement and UK CAT scores. So I think those things are important, but I think a good thing to think about with those is that you can, particularly with personal statement, you can perfect it and you can write a really good personal statement, and that's really to get you an interview, and that's what that will achieve for you. And then from there, getting a place is usually very much based on your interview. So it's kind of like a two-stage process, and once you've done your personal statement and any admissions tests that you need to do, you can move on to thinking about interviews and interview skills and how you can excel in that area too.